Oncology, Hospital da Luz, Lisbon, Portugal. He is an attending surgeon, Gynecologic Oncology Unit, Champalimode Foundation. He is an Inigo ESGO faculty on Introduction to Robotic Surgery. He is now a PhD student at the Nova Medical School, Lisbon, Portugal. He had his fellowship in gynecologic oncology at the Gynecologic Oncology Service, Department of Surgery, Memorial Sloan Kettering Cancer Center, New York, USA. He also had his fellowship in minimally invasive surgery, Changgung Memorial Center Hospital, Linkou, Taiwan. And he had his fellowship in laparoscopic surgery, Centre International de Chirurgie Endoscopique, Clermont-Ferrand, France. Friends, let's welcome Dr. Joao Casanova.
Thank you so much for the invitation. I really would like to say that it's a great honor to be here, and I would like to thank you to Dr. Sikam for inviting me, and it's a great pleasure to have you, to be here with you very early in the morning in Portugal. So without much ado, let me just get my things going. All right, so I think my presentation is going to be complementary to the great presentation that we had before. So I'm just going to talk a little bit of like operating room and setup of robotic surgery. So I have no conflicts of interest, except that I really enjoy robotic surgery. The brief agenda. I'm going to talk a little bit of GYN oncology and robotics, a brief review of the literature, just show you a little bit of the main components of the Da Vinci Xi, which is a little bit different from the SI. The trocar placement for GYN oncology procedures on the Da Vinci Xi, and show you a couple of videos of the docking part. Show what robotic surgery has allowed me to do, and a few take-home messages. So I think like it's important to start by the GOG Lab 2. It was published in 2009. Same oncological outcomes in endometrial cancer of MIS and open surgery. So minimal invasive surgery is feasible, it's safe, it has less complications and better quality of life for patients. So it's safe to say that MIS was established as a standard of care for endometrial cancer by that time. So this was published in 2014, and I just wanted to show you that the authors tried to evaluate how was the movement of outpatient benign hysterectomy in the US from 2008 to 2014. And what you can see is like that as robotic surgery was becoming more disseminated, there was a trend to move the patients from the inpatient setting to the outpatient setting. And that, as you can see on your right-hand side, was basically due to more robotic hysterectomies being performed. So the authors just concluded that from 2008 to 2014, the rates of laparoscopic hysterectomy and robotic hysterectomy both increased. There was a significant shift from inpatient setting to outpatient setting. And these findings suggest that robotic hysterectomy may facilitate that shift to outpatient benign hysterectomy, and particularly in patients with complexities. So, but what about our thing, our métier, like the French say? Well, what about GYN oncology? So this was published by my group at Memorial Sloan Kettering. They analyzed 200 robotic hysterectomies, 47% with a malignancy diagnosis, and 45% had complex procedures that the authors defined at least some lymph node evaluation, and 78% would discharge on the same day. This was also like an important paper that was published in 2019 at JAMA Surgery, and basically it's a Danish group, and they basically concluded that nationwide introduction of MIS robotic surgery for early stage endometrial cancer um, changed from open surgery to minimal invasive surgery, and that this reduced the risk of complications, and this was due mainly to the use of the robotic surgical platform. So what about the elderly patients? We all have like patients that are older with either endometrial cancer, ovarian cancer, but I think that the growth is like endometrial cancer. So this was also published by my former group at Sloan Kettering. They analyzed three groups of patients, 65 to 75 years old, 75 to 84 years old, and over 85. It was almost 1,000 robotic surgeries. 72% had a malignancy diagnosis, and the majority of them was endometrial cancer. And they concluded and they observed that it was safe in elderly patients. And of course, like even in open surgery, there was an increased risk for unfavorable outcomes in the over 85-year-old group. So like we discussed on the last presentation, in the severely obese patients, I think that's when robotic surgery plays a more important role, and especially because these patients usually have like endometrial cancer. So this paper just basically concluded that robotic surgery in obese patients with endometrial cancer is feasible, it's reproducible, and it's a valid alternative to laparoscopy, and it definitely reduces the risk of conversion in these patients. So in terms of like ovarian cancer, I think the evidence is growing. There's a lot of data out there on MIS in selected cases of early stage ovarian cancer, and this data it seems more robust. In the recurrent settings, well, so you have very well established surgeons and surgical departments that do in the recurrent setting for selected patients. And so it's never, it's always important to stress that you need well-trained surgeons and well-rounded surgeons to do these particular cases. There's this new trend about robotic surgery and also in the interval cytoreduction setting. Because I do a lot of extensive cytoreductive surgery as well. This kind of scares me a little bit, but the data is out there. So this was published by, I think it's an Italian group, and they did 91 cases, which 57 underwent robotic surgery, 82% of complete gross resection. The length of stay was 1 day. And I think like the most important, the key aspect of this is like you need to highly select the patients that you're going to take to the OR after neoadjuvant chemotherapy. This was another, but on the same setting. I think it was a Chinese group, 93 cases, 43 underwent robotic surgery, and they concluded that the use of robotic surgery did not affect the bulking success or oncologic survival indices. So I'm not going to lose my time to talk about like the LAC trial and the whole cervical cancer and the minimal invasive surgery controversy. Data is out there. I'm not going to talk about it. And we all know what happened after this. So what I'm going to show you here, this is from my previous institution, the Champalimaud Foundation. I just moved to a new hospital, but I also have the XI available. So the main components, like it was discussed before on the S side, so you have like the surgeon console. On your right-hand side, I was lucky because in my former institution, we had a dual console, which is pretty cool to teach younger physicians. And basically what you have is like the 3D viewer, which is great. It's immersive surgery. You have an enhanced vision of anatomy. You had the hand controls, intuitive motion. There's precise, without tremor. At the instruments tips, you have like like it was said before, the endo wrist. And of course, it's better to spend like a couple of hours sitting very comfortably than like being like standing all the time. So you have like the patient card, and this is the XI, so it's a little bit different from the SI. So you have the boom, which is like the structure that promotes flexibility and that allows you to position like the patient card arms over the surgical workspace. The universal arms, that's when you're gonna insert the endoscope, the instruments, and you're gonna dock the ports. And then you have a touchpad that's not shown here, but enables like everyone to move the patient card and select and adjust the boom height, improving all the setup efficiency. And then you have the vision card. On the vision card, you have like the touchscreen monitor. It's also good because it's high quality, it's HDR, and allows like all the OR staff to adjust vision settings and to troubleshoot stuff when you're sitting on the console. You have the electrosurgical unit, meaning like the generator, the Da Vinci generator for energy settings. And then you have the endoscope controller, where you have like all the stuff related to your camera. And then one amazing thing about like robotic surgery is you have like this plethora of instruments. You have like regular, like you can see on the right side, the monopolar scissors. You have like all your bipolar devices. On the middle picture, you can see like advanced energy devices. You have like this new instrument on your left-hand side. I think it's like the Synchro Seal, which is another advanced energy device. So you have the whole plethora of instruments that you can use. So trocar placement for GYN oncology, it's different from the SI and the XI. So on the XI, you need to use a straight line for port placement, except for the assistant port that should be like 30 degrees cranial to your robotic ports. As per recommendations of Intuitive, it usually should place your ports between 18 to 20 centimeters from the pubic symphysis, meaning just be above the umbilicus. If you're planning to do periaortic lymph node dissection, you should be a little bit closer to the umbilicus, and then you can do a redocking for the upper abdomen. The distance between trocars, it should be between 6 to 10 centimeters, and the recommended distance is 8 centimeters, which basically is like your wrist, your fist, sorry. So what you have here is like a little bit of a drawing showing that for targeted anatomy, you should be a little bit further away from your targeted anatomy, meaning like if you're targeting to do a hysterectomy, you should point the crosshair towards the bladder. This is almost like, you know, it's academic because the robot is so intelligent that he's going to correct the stuff that us humans that don't do properly. So basically, this is my setting for GYN oncology. What you have here is like a straight line of all the robotic ports. You see like the assistant caudally and cranially. You're going to see the assistant port that it's not on the same straight line. Just to allow for you for your assistant to better help you, because the robotic arms can collide and can just make their life miserable. That's true. So docking, for me, just a couple of pearls that my mentors in the US taught me. So know how to do it yourself. You need to be the most knowledgeable person in the OR for every aspect of every surgery. For GYN docking, you come from the right side of the patient. So it's usually you have like the settings, it's pelvic right. And you should like my previous, like the previous presenter said, strive for have ergonomy in the OR, because everything will be more smoothly and the flow will be much faster. So I'm going to show you just this first video. This is I'm sorry for the sound. This is my scrub nurse just trying to start things, meaning she's just like putting all the robotic arms in position. You can see the boom that has like the crosshair on top right here. And so she's just putting the arms on the exact position before she does the docking. So it takes like the time that you're seeing here is exactly like 25 or 30 seconds, and that's it. That's part one. So that's the next video that I'm going to show you here. It's the docking part. So you have the unscrubbed or the circulating nurse just driving the the robot by itself to the surgical field. I'm there just like signaling, which is the port that I'm going to introduce the endoscope. So you need the crosshair to be like a little bit on top of that port so the setting is better. And then you're just going to dock first the endoscopic arm, and then you're going to dock the other ones. So in the third video, it's a little bit longer, but this is just because when people talk about robotic surgery, they all say, oh, it adds some more time for in the OR than when compared to laparoscopy. It's true, but it adds, I think, 5 minutes on a well-rounded OR team, familiar with robotic procedures. So here you go. And this one lasts exactly 3 minutes. That's how much it took me for this surgery to have everything ready and just go to the console. So the same, the robot is coming. You see the crosshair on with the right, the green. So I'm just telling them to load the boom a little bit. And I'm just gonna connect like the arm number 2, which is usually the one that you're gonna put the endoscope in. So it's easy peasy. It's nothing much. It's easy, it's done. So I'm introducing like the scope right now, and I'm gonna do like the aiming, which is also nice. Sometimes people when they're like so proficient in robotic surgery, and because yes, we're working in the pelvic cavity, there's nothing much, so they target or they don't target, but targeting makes it more ergonomic. And as you saw, I was pointing towards the bladder and not the uterus. So now I'm docking like the arm where I'm going to put my bipolar on arm number 1, arm number 3 that my assistant is docking right now. We're going to put like the monopolar scissors. So also the robot is like very smart and he can guide you. You don't need to be like looking to the instrument, but it's, of course, it's much better. It's more safe, but you can put it like when you become like familiar with it. And here I'm just pointing the camera to see where I'm going to put my instrument, and you're going to see on that screen that it's coming in. There you go. So I have the bipolar set. What I did now is just like something that's very important. We call it like the burp. So it releases tension of the trocar in the fascia. So now I'm helping my assistant to put like the monopolar scissors. He's docking like the 4th arm where we're going to put the ProGrasp, which is like the retraction instrument. And sometimes it's a little bit more difficult because you have like the other arm connected, but usually it's like pretty straightforward. There you go. So now we're gonna give him like the monopolar scissors, which is gonna go on arm 3. You see the sound, and then you get to push the button that allows you to control the instrument, which is right here, this one. So I'm showing him, and the scissor is in. Now I'm showing him, like, if you see here, that's trocar number 4, and he's going to put the retraction instrument over there. Then you need to guarantee like there's a space between all the arms, so you don't need to scrub in. So you don't need to, this usually takes like 45 minutes to do like a hysterectomy. So it's supposed to be like smooth and fast, and you don't want things like to ruin like how fast it should be going, and you should be moving. So right here, I'm just like trying to have a little bit more of space in between my arms. So this was because Dr. Sikam asked me a little bit of like some real life surgery. So I'm just going to show you a little bit of the video. This is like an endometrial cancer video. So I'm just opening spaces and developing. What you can see here, it's that you don't have with straight stick laparoscopies, like this magnified video. So you can see like small blood vessels, you can see structures. To the people that rightfully say that you don't have like the grip feel of touching the instruments like when you're doing minimal invasive surgery. Yeah, but when you become experienced, you know the traction that you should put on tissues, you know exactly what you're grabbing. So you saw the ureter there. So I'm here just finding like the obliterated umbilical, dividing the round ligament. One thing that it's key and it's mandatory when you're doing robotic surgery, even more than in laparoscopy, you need tension. So you need tension. You need to be constantly moving and adapting. If it's the scissor is not cutting, that's because you're not doing tension with both of your retraction arms. So I'm trying to find and develop like the paravesical space. So I found the obliterated umbilical right here. So as you can see, it's precise. So I'm going to have a little bit bleeding here. You can like see it, clean the field, keep your operative field clean. It's especially important when you're doing like sentinel lymph nodes for endometrial cancer. So do some precise dissection so you don't have like all the lymph node channels burst and open, and it's going to be like a mess to try to see where or the sentinel lymph node maps. So it's easier, it's faster. Like in the previous presentation, it's you have like a faster learning curve, so it's more democratic robotic surgery. You can start doing procedures way faster, and I think that's one great advantage of it, because if you have more surgeons doing MIS, you're going to have less laparotomies, which is, I think, it's the main goal here. So paravesical space developed. So you're going to see here the channel coming from medial to lateral across the obliterated umbilical. That's where you're going to find like 80 to 90% of your sentinel lymph nodes. So it's right over there. So I'm just going to push it a little bit forward, so to show you a little bit on this part here. So I think that then you can see again, channel, medial to lateral, and I'm going to have like my sentinel lymph node here, right on the obturator space. Then it's just dissection, dissection. I have the lymph node here with me. I'm just going to show you a little bit of one thing that I forgot to tell you is, like, because with the robot, you have like the infrared view on the tip of your finger. So it makes this surgery, I think it makes sense to do robotic endometrial cancer cases with sentinel lymph nodes, because it's so easy. You don't need any extra device, any extra camera. It's all there in the robotic platform. That's it. So dissection, dissection, and just taking like the lymph node out. And you're going to see how it looks, and it's done. Just going to show you the green part, which I think it's going to come right now. So you can see like this is the correct sentinel lymph node. And there you go. So what has robotic surgery allowed me to do? So I started doing robotic surgery in my fellowship in 2015. So I've done well over 400 procedures, most of them with a diagnosis of malignancy, or at least a frozen section was required. My median length of stay is 1 day, and fortunately I've had no major complications, no takebacks, no conversions. And I think that what allowed me to do is a little bit more of precision medicine, especially in the cases like I've shown you before, like sentinel lymph nodes in endometrial cancer. And I've done like some recurrent ovarian cancers too, well-selected cases with pelvic or one abdominal site for recurrence. So in terms of take-home messages, not to take so much time from you, and so we can have a little bit of discussion. I think robotic surgery is the present and future of MIS. It has a fundamental place in GYN oncology, in endometrial cancer, ovarian cancer. Not going to talk again on cervical cancer in the LAC trial. And like I said before, one thing that I love about robotic surgery is like it's democratic. It has a faster learning curve. You have more surgeons doing MIS. You have less laparotomies. And that's the whole point, without compromising, of course, our oncologic outcomes. So just a little talk a little bit more about me. So I also do training of Migo, and we have like this basic robotic skills course. It's in this July. I think it's already sold out, but I'm more than welcome to have like my colleagues from the Philippines. And that's it. And thank you so much for having me here.
Thank you very much for that excellent lecture, Dr. Joao.